I am really honored and thankful to Endocrine Society of India for giving me this opportunity to present this important topic, diagnosis of primary hyperaldosteronism. So, without wasting further time, let me begin. Let me start with a case. We have a 61-year-old male who was apparently well 14 years back when he was found to have hypertension. He was started on telmisartan 20 milligram once daily, and doses were gradually increased. He took telmisartan 40 milligram for around 12 years and BP remained around 140/90. Now, 3 years back, he had an episode of sudden onset breathlessness. He had to go to emergency for that, and blood pressure was found to be 210 by 110 and a potassium of 1.6. However, he did not follow up after discharge. 2 years back, he again had a similar episode. Similarly, blood pressure was 238 by 110. Again, discharge on two antihypertensives and full workup not done. Coming to patient 2, she had a similar history, 52-year female, apparently well 13 years back, diagnosed to have hypertension, initial blood pressure 190 by 100, started on unknown antihypertensives, doses increased over the years, initial blood pressure control on 2 antihypertensive, 4 years back, had a fainting episode, blood pressure was 230 by 130, she was given antihypertensives, asked to come for follow-up. Now she used to have these episodic headaches and accelerated hypertension once in 2 months, and blood pressure used to go around 230 to 270 and 120 to 150. Her antihypertensives up titrated to 3 medication, but she continued having high blood pressure. She did not have any documented hypokalemia. I'll come back to these cases. So the question is, what would you do next in these two cases? The option A is normalize serum potassium and test aldosterone renin, obtain CT scan of the abdomen, prescribe spironolactone, screen for diuretic use if there is hypokalemia, or get plasma metanephrines and normetanephrines. Now, nothing to start with. We have the schematic of the adrenal gland, and this is the common pathway of cortisol and aldosterone secretion, which begins from cholesterol, and zona glomerulosa secretes aldosterone. So again, this is the aldosterone signaling pathway, and angiotensinogen is converted to angiotensin 1, which is further converted to angiotensin 2, which stimulates aldosterone, which causes sodium chloride reabsorption, potassium secretion, and H2O reabsorption, hypertension, arterial stiffness, and cardiac remodeling. It's not just about increased blood pressure. Aldosterone has pleiotropic action contributing to the pathogenesis of cardiovascular disease. It increases oxidative stress and causes endothelial dysfunction, cardiac and vascular fibrosis. Hypertension obviously is there, causes dyslipidemia, even obesity, diabetes, gluconeogenesis, and increased sodium reabsorption, potassium excretion, causes CKD. So it's not just about controlling the blood pressure, it's about targeting the pleiotropic actions. Scope of the problem: hypertension is an important public health challenge, and it contributes to the global burden of cardiovascular disease, stroke, and premature mortality. In majority of patients, hypertension is found to be primary. A subgroup of patients may have a secondary cause. In young patients, it's all the more important to look for secondary cause of hypertension. High prevalence of hypertension is there in India. A recent survey, it has shown that 30% patients, 30% is the prevalence of hypertension, and in young patients in the 18 to 39 years old, prevalence is 19%. Now coming to primary aldosteronism, it is currently minimally at least 5 to 10% of hypertension it is recognized to cause. Now, approximately 1.3 billion adults, people globally suffer from hypertension. So if we use even any conservative estimate of 5 to 10%, even prevalence may be even higher. So total number of people having primary aldosteronism would be extremely large. And there is paucity of data on the prevalence of PA, especially in the developing world. Now coming to who should be screened for PA. So these, the right side and left side, these are from the Williams textbook of endocrinology, 2016 edition and 2019 edition. They've made the changes. This is from Dr. Young group from Mayo Clinic. And initially these are the same from Endocrine Society guideline. So these are the patient, actually they constitute the overt group. That is hypokalemia, resistant hypertension, adrenal incidentoloma, severe hypertension. So at least they should be screened, but even in reality, they are not screened. And then we have the expanding indication that all patients with hypertension should be screened at least once in lifetime. The changes made is that it is gradually being realized that aldosterone, it's not like all or none. It is also a spectrum, and we are finding hypertension, aldosteronism, even in patients having mild hypertension, even in stage 1 hypertension. And so it's not like we can have this cutoff of 15 nanogram per deciliter. So there is this trend to decrease the cutoff so that more patients could benefit from treatment. So they have decreased this aldosterone cutoff from 15 to 10. And instead of ratio, absolute values of aldosterone and renin should be looked at. Now, what prevalence of cardiovascular disease and its factor in primary aldosteronism? This is PA database from multi-center JPAS study, and they have found that the prevalence of cardiovascular disease, stroke, was higher among patients with primary aldosteronism than those with essential hypertension. So patients with PA presenting with hypokalemia, unilateral subtype, or having very high aldosterone secretion, they are at a greater risk of cardiovascular disease and have a greater need for PA-specific treatment than others. So why should we screen for PA? Number one, patients with primary aldosteronism have a substantially higher risk profile. 4 times increased risk for stroke, 6 times for non-fatal MI, 12 times for atrial fibrillation, then age match, sex match, and blood pressure match people with essential hypertension. Secondly, patients with primary aldosteronism, and incidentally, patients with resistant hypertension and so-called low renin hypertension. MR antagonist may be the game changer, and treatment with conventional antihypertensive drug alone is clearly inferior. Hence, it is not just a matter of lowering blood pressure. Nullifying the effects of excess aldosterone on sodium status is also the key. Now, what is the ground reality of poor screening worldwide? It remains profoundly underdiagnosed. Despite the large number of studies indicating the prevalence, high prevalence, and that this disorder can be treated to modify cardiovascular risk, this information has not yet translated to higher screening rates. And even in high-risk group like resistant hypertension, where prevalence of PA can be even up to 25 to 50%, even there, screening rates are, I would say, abysmal. So this study is from Graff et al, and these data, they are from USA. We don't have any data from developing countries. We can expect the conditions to be even worse. So this retrospective cohort, 1,45,670 people with hypertension, 3.7% had resistant hypertension, and of those, only 2.1% were ever screened for primary aldosteronism. So why is the poor screening rates? This also we will discuss. Now these data, they are from Canada, and primary aldosteronism of the 1.1 million adults with hypertension, 7,941, that is 0.7%, were screened for primary aldosteronism. So less than 1% patients expected to have primary aldosteronism were ever formally diagnosed and treated. This is our study from India, and we have recruited young hypertensive patients, that is, those who had onset of hypertension less than 40 years of age, and we found the prevalence of primary aldosteronism to be 17.8%. Although we have referral bias, the patients, they were referred for workup of secondary hypertension, so that could be responsible for high prevalence. But still, this is very important because we don't have any previous data from India, and such high screening rate shows that larger studies should be conducted to see the real prevalence of primary aldosteronism in primary care. So why don't we screen enough? One cause is lack of education provided to primary care providers. Second is that efforts to increase awareness among those clinicians, they are critical, and that is not being done. Many clinicians are also intimidated by the complex diagnostic algorithm requiring several hospital visits, and legacy memories of being taught that primary aldosteronism is a rare and benign condition. But in reality, it is neither rare nor benign. So one question which is often asked in the setting of developing countries, the developing world, the cost of screening. Although more studies need to be conducted regarding this, but this study published in Circulation 2015, a decision analytic model compared aggregate cost and systolic blood pressure changes, and CT scanning followed by adrenal venous sampling was a cost-effective strategy to screen for primary aldosteronism among patients with resistant hypertension. So, coming to the classification, what can be the types of primary aldosteronism? It can be aldosterone-producing adenoma 30%, bilateral idiopathic hyperplasia 60%. The rest are the rarer forms like unilateral hyperplasia, aldosterone-producing carcinoma, and familial hyperaldosteronism. Now, this is from the Endocrine Society 2016 guideline. So they have used ARR as a case detection tool. And if the patient is having spontaneous hypokalemia, low renin, and aldosterone concentration more than 20, in that case, even confirmatory test can be spared. Then coming to next step, we have to do adrenal CT. And if the patient is again having young age, for young age, they have used a cutoff of 35 years and a clear-cut adenoma on CT, the patient can directly undergo laparoscopic adrenalectomy. Now, it is very, very important to understand this, what are the medications effect on aldosterone-renin ratio. So what we see that there are various medications which can interfere with aldosterone-renin. So when we see a patient, and it is always not possible to stop all the medication, so we can interpret his results if we know how a particular medication will affect aldosterone and renin. So we see that beta blockers and clonidine, they decrease aldosterone. So if a patient on beta blocker is still having high aldosterone, so it is highly significant. Similarly, on diuretic, they also cause false negative. So despite that, if the patient is having positive ARR on diuretic, that is also significant. So we can interpret the result on the basis of, if we already know how the particular medication will affect the aldosterone and renin. Coming to screening protocol, there are multiple factors which can affect the aldosterone and renin. In patients aged 65, renin can be lowered, so that can cause raised ARR. Then premenstrual ovulating females have higher ARR levels. Then the diet, medications, level of potassium, level of creatinine, renal failure can lead to false positive ARR. It is difficult to diagnose if the patient is already in CKD 4 and 5. So most important factor is to correct hypokalemia. encourage patient to liberalize rather than restrict sodium intake. If possible, ideally, spironolactone mineralocorticoid receptor antagonist should be withdrawn for 4 weeks. Other drugs, if the results are borderline, I mean, the patients we are seeing, the overt patients, they will not be affected by these medications. It is important to withdraw spironolactone, but other medication, the usual antihypertensive medications, they can be continued. Then the patient should be in a seated position for 5 to 15 minutes. And it's important to maintain sample at room temperature, not on ice, as this will promote conversion of inactive to active renin. So now coming to cutoff, the units are again intimidating for a person interpreting the aldosterone renin report. Some laboratories use PRA while others use DRC, which assay. So that is again a complex workup. So if we are using aldosterone in nanogram per deciliter, PRA in nanogram per ml per hour, then in terms of PRA units, the 30 cutoff is the most commonly used. And in newer diazorin assay, in terms of DRC units, it converts to 2.5. Now, coming to international guidelines, Endocrine Society guideline I've already described. Then we have French and Japan Endocrine Society guideline. French Endocrine Society guideline, they use a cutoff of ARR 30 and a minimum aldosterone of 9. Japan, they use a minimum aldosterone of 12. Now coming to confirmatory testing, they are the 4 commonly tests which are done to establish the diagnosis, that is oral sodium loading, saline infusion test, fludrocortisone test, and captopril challenge test. Now oral sodium loading and fludrocortisone test, they use 4 days, and the sample has to be collected on 4th day. So some hospitals, they use the protocol of admitting the patient for 4 days. Otherwise, the patient has to make multiple hospital visits. What we use at our institution, AIMS, we use saline infusion test, and we do it in recumbent position. Patients stay in the recumbent position for at least 1 hour before and during the infusion of 2 liters of 0.9% saline over 4 hours. The cutoff, less than 5 is negative, more than 10 is positive, 5 to 10 is intermediate. There is a version of it, a modified approach of seated saline infusion, and that uses a cutoff of 6 nanogram per deciliter. Now, the next step. Now we have confirmed primary aldosteronism biochemically by doing confirmatory test. So what should be the next step? Why should we do subtyping into unilateral and bilateral? Why not we straight away start the patient on aldosterone antagonist? So this study from Lancet, cardiometabolic outcomes and mortality in medically treated primary aldosteronism. In this 602 eligible patients, incidence of cardiovascular events was higher in patients with primary aldosteronism on MR antagonist than in patients with essential hypertension. Patients with primary aldosteronism had higher adjusted risk for incident mortality, diabetes, atrial fibrillation. So we are not able to nullify the aldosterone effects despite giving MR antagonist. In the subgroup where we were able to raise renin, that is, we have to, even those who have been diagnosed primary aldosteronism, they are not treated properly. They are treated suboptimally, and the risk of cardiovascular poor outcome, it remains high. If we are able to treat it appropriately, that is, if the patient is having unilateral PA, the ideal thing is to get it removed, to remove the source of aldosterone excess. Unilateral adenoma has to be removed. And if we are treating the patient with MR antagonist, we have to raise the renin appropriately to mitigate the excess cardiovascular risk. It is very important because despite making the diagnosis, we are not treating the patient optimally. Now, coming to adrenal venous sampling, the basis. The adrenal venous sampling is performed to assess whether autonomous hormone production is unilateral or bilateral. Macroscopic appearance, whether it be hyperplasia, nodular disease, or other, it is irrelevant because the main differentiation is whether secretion is unilateral or bilateral, as those with unilateral secretion can be offered surgery. So we have this AIMS protocol. We start with synactin infusion, that is ACTH infusion at the rate of 50 microgram per hour, 30 minutes before the procedure, and we collect sample for cortisol and aldosterone in the following order: right adrenal vein, infrarenal IVC, left adrenal vein, and infrarenal IVC. This is the most important indices. Selectivity index is that whether we have cannulated the adrenal vein or not. So that can be known from the cortisol secretion, because if we are able to reach the adrenal vein, then the selectivity index would be at least 5. Then only we interpret the result further. Then the lateralization index. Lateralization index is the lateralization of aldosterone production. So lateralization index more than 4 is there for unilateral primary aldosteronism. So now coming back to our patient, the patient number 1, the 61-year-old who had hypokalemia and episodes of accelerated hypertension. So when he came next day, his to our clinic, blood pressure was 180/96. He then consulted a private practitioner who started him on amlodipine, telmisartan, and chlorthalidone. His blood pressure remained poorly controlled. He continued having multiple episodes of hypokalemia. He was started on spironolactone by a private practitioner. Again, at that point, he has not reached it actually. When he came to us, then we stopped his spironolactone for 4 weeks. And then we did this aldosterone renin and we evaluate. The aldosterone came out to be 46.4. I have told the cutoffs from different guideline: 9 from French Endocrine Society guideline, 12 from Japanese Endocrine Society, and 15 which was previously used from Mayo Clinic. So this guy is having 46.4. This aldosterone is way too high. And the renin concentration is 1.6. The ARR in terms of BRC unit, it is coming to 29. We have 2.5 as the cutoff. So these values are way too high. We did saline infusion test in this patient, although technically it can be obviated also because he was having spontaneous hypokalemia and his baseline aldosterone is too high. That came out to be 27.5. 5 is the cutoff. CT scan showed a clear, well circumscribed nodular lesion from right adrenal, but left adrenal also showed some abnormality. Given the age of patient, we did adrenal venous sampling in this patient. Now, the right adrenal aldosterone value is 48,500. First of all, we have to check the selectivity index, that we have reached the adrenal vein or not. It is more than 5 that we have reached the adrenal vein. Now, both sides, we have the value of around 20. That means we are well inside the adrenal vein. Now, the lateralization index of this patient is coming to be 131.4. More than 4 is positive. So this patient is clearly having right access. This patient underwent right lap adrenalectomy, and he is now in clinical and biochemical remission. Now coming to patient 2. This 52-year-old female who had multiple episodes of accelerated hypertension, and she did not have hypokalemia. When we did aldosterone ARR for her, this also she's having baseline aldosterone of 30.6. These values are also quite high. DRC of 1.3. Again, she's having ARR of 23.5. So the cutoff is 2.5. It is quite high. The saline infusion test we did for her, the post saline is coming to be 12.5. 5 is the cutoff. Now CT scan for her is showing left adrenal myelolipoma 1.8 centimeter. We did adrenal venous sampling in this patient. Selectivity index, we are able to reach inside the adrenal. So the right side is 23, left side is 26. So we are well inside the adrenal vein. The lateralization index is coming to be 2.1. The previous patient was 131. So this is a case of bilateral access. She was started on spironolactone 50 milligram. Doses increase according to renin in follow-up, and all her other antihypertensive medications were withdrawn completely. When the question which I asked initially, so what would be the next step in a patient who is coming with hypertension, hypokalemia? So we have to normalize serum potassium and test for aldosterone and renin. So what are the approaches to avoid AVS? There are several approaches like NP59 SPECT-CT and metomidate positron emission tomography PET-CT scans. These scans, actually, they rely on excessive uptake by cells overproducing aldosterone of a labeled steroid precursor analog. But whether this will render them sufficiently sensitive and specific to be suitable for routine clinical use and to be considered substitute for AVS. This will require validation in different centers. So as of now, the gold standard, it remains the AVS. So how do we follow up the patients who has undergone adenectomy? This is a very beautiful study by the Williams TA group, published in Lancet Diabetes Endocrinology 2017. This is the PASO trial. So they have said that we assess by complete clinical success, partial clinical success, and absent clinical success on the basis of defined daily dose of antihypertensive medication. Then we say complete biochemical success, partial biochemical success, or absent biochemical success on the basis of the aldosterone value. And if the aldosterone value is more than 5 nanogram per deciliter, that is the cutoff for confirmatory test. So if it is more than that, then we do confirmatory test again in follow-up, and we assess whether the patient is having persistent hyperaldosteronism or not. Outcome assessment should be done in the first 3 months post-surgery, but final outcome should be assessed at 6 to 12 months. Outcome should be reassessed annually. So this is a wonderful review from the Dr. Vaidya group from Harvard, and they have again the screening indications. Essential indication, severe resistant hypertension. Expanded indication, any stage 2 hypertension. In fact, any hypertensive. That is the expanded indication that we will take some years to reach, but we will reach there. So we have to measure plasma renin and aldosterone. Instead of ratio, we just focus on individual value of renin and aldosterone, and we see whether the renin is suppressed or not. If the renin is suppressed, then we see the aldosterone value. If the aldosterone is more than 15, then the patient is having overtly positive. If the patient is having potassium of less than 3.5, then we do not need to do confirmatory test. Even in such patients, it is confirmed. We can repeat renin and aldosterone on a future date to confirm. If the patient is having 5 to 15, that can also be a positive screen, and the patient may have mild primary aldosteronism. The next step after confirmation is to go to imaging. And if the facility of AVS is available, to go to AVS. If it is not available, or if the patient does not want to undergo surgery, we can start on MR antagonist therapy. If the patient is having aldosterone less than 5, then the patient is likely not having primary aldosteronism. Now, after that, when we confirm primary aldosteronism, the unilateral disease is confirmed by AVS, then the patient has to undergo unilateral adenectomy, and we evaluate for biochemical and clinical cure, as mentioned in the PASO trial. When the patient is having bilateral disease, then lifelong MRA therapy is advocated. But still, how can we know that we are giving optimal MRA therapy or not? That the patient has normalized blood pressure, patient has normalized serum potassium, and it's very important that the patient has increased renin. renin is actually a surrogate marker of normalization of the aldosterone excess. There is an option of even non-curative unilateral adenectomy in such patients if the patients they remain to have persistent hypertension and suppressed renin. This is how we go about diagnosis primary aldosteronism. In primary aldosteronism, we are not addressing even the tip of the iceberg. Thank you.